Can you hear me?
And we can hear you perfectly.
Oh, how was that annoying admission and discharge yesterday? I'm really still feeling horrible about it. David is inundated with so much work, he can't hear me. Okay. All right, guys. So we're gonna go through in the next 45 minutes through about like 6 case scenarios, and really just trying to sort of mimic real world questions that were asked often by consulting teams or even for our own patients that are heading for procedures. So, my learning objectives today are to underscore the clinical scenario where anticoagulation interruption is not needed, right? So it's important to understand when you can just keep going with it. The second thing we're going to do is to explain how to bridge Coumadin, so your warfarin, which is a vitamin K antagonist. So how to bridge it when you do need to interrupt your warfarin. The third thing we're going to do is to present a pharmacodynamic strategy to the interruption of your DOACs. And the last thing we're going to do is understand the recommendation of timing of surgery in patients on DAPT. I'll give you my resources at the end. There's a lot of great resources, especially for those going into cardiology. More in-depth, detailed reading. So who are these patients that we're discussing today? Long-term oral anticoagulant therapy is often used in patients, obviously, with atrial fibrillation, mechanical heart valves, or venous thromboembolism, right? So older people, as I'm sure is like 90% of the people that you're essentially looking after, are both more likely to need anticoagulation, right? Because they're more likely to have AFib, they're more likely to have had mechanical valves, and they're also more likely to require surgeries, right? So it's a fragile population that has this sort of combined sort of conundrum of being on an anticoagulant and heading towards surgery. And so it's actually estimated based on a lot of randomized trials that in patients with AFib, which is really at this point, if you look around your patient panel, the dominant clinical indication for long-term anticoagulation, about 10 to 15% will require treatment interruption annually. So just in 1 year, you will notice about 10% of your panel heading towards some elective surgery or procedure. And so it's an important skill to acquire, whether you're going to be a primary care doc, cardiologist, even as a resident, because you're, doing MC roles and you're doing POMAs. So the interruption of therapy can increase the risk of thrombotic events during and after surgery. However, the non-interruption of these medications can heighten the risk of bleeding during surgery, right? We know that, and it can trigger sort of a sequence of undesirable outcomes. It could be major, minor bleeding, sort of the things the surgeon is afraid of. So when you show up at someone's bedside or when they're coming to your office, you're doing a bunch of different things. You're saying, I need to evaluate this individual's underlying bleeding risk and clotting risk. You're doing both. I need to figure out what is the surgical procedure they're going for. And sometimes I need to pick up the phone and say to the surgeon, how often do your knees bleed? How often do your hips bleed? Sometimes it's fairly obvious to you what the bleeding risk is, and other times it's not. And it's okay to ask the surgeons that question. What is the bleeding risk associated with their surgical procedure? And then when you're done with that, your next job is to figure out the timing of interruption, but it's also your job to figure out the timing of resumption of the anticoagulation therapy and whether or not you're going to bridge. Okay, so we're going to dive into our first case, and the way I'm going to do it is to eat my Greek kitchen while one of you reads. The chicken is horribly dry today. David, can you read the first case for us?
Sure. So this is DE, a 45-year-old man, coming in with 2 days of dental pain from a tooth infection for which his dentist has recommended an extraction. He has a spontaneous DVT diagnosed in his left femoral vein 2 months ago. He's been taking warfarin since then, unable to afford a DOAC because he does not have health insurance. INR has been a target for the past 6 weeks. Most recent was 2-4. Which of the following anticoagulant management approaches is most appropriate for this patient?
Wonderful. And Sani, if we can do the poll. Thank you.
Okay, guys, just keep moving.
Okay, my bite of chicken was so big. Take your time.
We're not to 50% yet. We can wait till 100 as long as you need.
Really big bite. I didn't realize, Francisco, you like read it out when you mouth the words when you're reading. My husband does that.
All right, at 50. Wow, I didn't know you could change your minds. All right, 55%. Just keep voting. Come on, you know this. All right.
Francisco, do you want to just unmute yourself and tell us what's the right answer and why?
Yeah, I mean, overall, I think one of the most important things is whether to ask the dentist how he feels comfortable, but usually there is bleeding risk when you extract the teeth, so clearly you need to discontinue the warfarin, and usually they feel comfortable with a low INR. The ones that are 24 hours clearly is not correct, because vitamin K antagonists, they need more than 24 hours for the INR to go below 2. So I feel comfortable with the answer number 4, although I'm not 100% sure.
The dentist will like you as a cardiologist, right? Because they were like, look at this guy, like always interrupts his anticoagulation for us. He's a good friend. So I think, part of it is like the first thing that we set out to do, which is to define who to interrupt and who not to interrupt. And a lot of work has been done on this, and various trials have been done on this, right? Where they've sort of randomized the interrupting versus not interrupting. And based on data so far, it seems that it is reasonable to continue oral vitamin K antagonists and DOACs, so both warfarin and all of the new ones that you guys have gotten so used to using, for various procedures. And these procedures include, very broadly, dental extractions, dental implants, which are becoming super common, cataract surgeries. These cataract surgeries are nearly bloodless. And so these phacoemulsification, where they use a little topical anesthesia, quite safe to not interrupt. Things like diagnostic GI endoscopies when they're not biopsying something vascular, like AFib catheter ablations, arthrocentesis procedures. And so while I agree with you, Francisco, that I think it's a really good idea to call the dentist and say, what do you prefer for me to do? What has been your own prior experience? Who is this patient? The larger data actually suggests that you can simply continue throughout, for certain procedures. And so where does the data come from? It comes from now almost a decade ago. They did this. I really like some of the names of these studies. The 2013 bruise control, right? It's easy to remember. So they in this randomized control trial, they took 681 patients who were on warfarin for atrial fibrillation, and they were heading towards a pacemaker implantation. And they randomized to saying you could either go uninterrupted, right? So just continue your warfarin throughout the procedure, or we'll stop your warfarin, bridge you with low molecular weight heparin, which they used for bridge control in 2013. They used enoxaparin. And they said, let's look at some of the outcomes. And so interestingly, the patients who continued warfarin had a lower rate of pocket hematomas, right? Because they're doing pacemaker implantations, than those who were bridged. And it was a sort of startling difference, right? 3.5% for those who were continued on their warfarin, and 16% for those who were interrupted and bridged. More notably, the rates of thromboembolism, cardiac tamponade, or death were not different between the two management approaches. So that's worth remembering. The second trial that's worth noticing is just a year after the bridge control came out, came the COMPARE, and it stood for something like Coumadin preventing thromboembolism in atrial fibrillation patients undergoing catheter ablation, something like that. I could have just made that up, but I think it's that. So in this randomized control trial, also very large, over 1,500 patients were allocated to receiving warfarin or to interrupt again with low molecular weight heparin. And again, startling sort of revelation, 5% versus 0.25% when you compare the thromboembolism events in interruption, in no interruption versus interruption. So again, sort of in favor that if it's a procedure that doesn't traditionally bleed as sort of a small surgical procedure, consider just continuing. You don't need to interrupt and you don't need to bridge. And then they did another version of this in 2018. They did what is called the Bridge Control 2. And if you Google Bridge Control 2, you see this beautiful sort of graphic. And essentially this time they did it for, you know, sort of very similar to Bridge Control 1. And in this, they said it doesn't, the sort of outcomes weren't really dramatically different. So do either or based on your patient, right? So we'll move on. Any questions for this? And you know, just going back to the STEM and who this guy was, right? I agree with Francisco in a very sort of, at a very basic level, which is call the surgeon. Always find out what the surgeon's preference is and then discuss the data. And then, you know, as a medicine, internal medicine PCP or cardiologist, you know, you have a lot of data to rely on if the surgeon is saying, oh, no, you need to stop your warfarin. Okay. Yasmin, do you want to read the second question?
Sure. So MS is a 72-year-old lady with recently diagnosed uterine cancer. She comes to the Ryan Clinic before her abdominal hysterectomy. 10 years ago, she had a mechanical heart valve replacement for mitral stenosis that was rheumatic in origin. She has known chronic kidney disease, but no history of atrial fibrillation or stroke. She takes warfarin 5 milligrams daily. Labs are stable. Labs stable creatinine 3.5 with a GFR of 15 and INR 2.7. Which of the following pre-op anticoagulation bridging strategies is the most appropriate?
Just realized, Sani, we didn't share the poll, right? You want to share it now?
The poll?
The first question.
We did momentarily. I wasn't sure because we went right into the discussion.
As long as everyone saw the general poll, that's perfect. And if you're noticing, like, patient DE was dental extraction, patient MS, I'm a very creative question writer. Patient MS has a mechanical valve, if it sticks to memory at all. Okay, so we've been through the question. We can open up a poll. This one I think is a lot easier, right? This is not really much of a close the poll out in 20 seconds and show the results.
And keep voting, guys. We're only at 12%. You guys have us.
If you need to look at the question stem again. Notable things about this person, they're 72, has a mechanical heart valve for mitral stenosis, so it's a mechanical mitral valve. PD, therapeutic on her Coumadin. She's heading towards, she's heading towards a major surgery. It's an abdominal hysterectomy. They're gonna open up her belly.
Can we share the answers?
Yeah.
Did you share the results, Sani?
Not yet. We're only,
Okay.
oh, there we go. 50,
Oh.
there we go.
Okay, brilliant. Yeah, so there you go. All of you doing your POMAs. Exactly right. So patients with mechanical mitral valves, right, are high risk for valve thrombosis and therefore stroke and also for arterial thromboembolism, and they require anticoagulation with low molecular weight heparin or unfractionated heparin, right? Depends on their kidney function, both before and after surgery, right? So if we go back to patient MS, if I change this, right? If I change the stem, to 10 years ago, she had a bioprosthetic aortic valve for aortic stenosis, right? Let's say I changed it from what MS is to like AS. Would you choose differently?
So I was actually going to ask you because there is a question in New World about it. So technically, if the patient had an aortic mechanical valve, then you don't have to bridge because it's like the flow is different, so you have less risk of thrombotic events. But they do mention that for mitral valve stenosis with mechanical valve, the INR should be below 1.5 instead of 2.5 when you're undergoing a high bleeding risk procedure. So I wanted to ask you about that.
Good. Yeah, look at that, you world. Any budding cardiologists? Well, like, why is there a difference? Like, instead of Francisco teaching the whole lecture, why is there a difference between mitral and aortic?
I thought you mentioned bioprosthetic valve, not mechanical for aortic in that scenario, right?
Good.
That
Okay,
scenario
let's
wouldn't be
also, Joe, let's also throw in mechanical. Let's say mechanical aortic, like Yasmin mentioned.
So yeah, as Yasmin already said, that aortic is a high gradient, high flow valve, so the risk of thrombosis is lower. But I think if it's mechanical, she should still be bridged with anticoagulation even, but probably the INR would change the level because the therapeutic would be 2 to 3 instead of 2 to 2.5 to 3.5, but she would still be bridged with IV heparin.
Yeah, so this is sort of the only aortic, whether bioprosthetic or mechanical, right? So if you have a patient with a bioprosthetic mechanical or bioprosthetic or mechanical aortic valve replacement, but they don't have atrial fibrillation, right? And they've never had a prior stroke, right? So this is sort of an isolated valve with no risk factors besides the valve itself. You don't need to bridge. Does that make sense? So you would simply not bridge. You would simply interrupt the warfarin, not bridge, head towards surgery, and then resume the warfarin. It's highly controversial, but there's a lot of data to support that in the absence of risk factors such as AFib and prior stroke, for isolated mechanical or bioprosthetic aortic valves, you could skip bridging. And that's
so I have a question about that. So you won't interrupt, you won't bridge rather, but like when to reinitiate, do you have to go to warfarin straight away without a heparin?
Yeah, like, exactly. That's exactly right, lady, because we're saying that you've never had a stroke in your life and you don't have atrial fibrillation, right? So post-operatively, you would simply resume your vitamin K antagonist and build it towards your therapeutic INR again. Because you're saying that in that interruption window of 10 days, like let's say like 4 to 5 days pre-op and 4 to 5 days that it sometimes takes you to build to that therapeutic INR, that your stroke risk is simply so low that there is no need to bridge. Is it making sense?
Okay. Yeah, thank you.
Yeah, the reality is, I don't know how many patients you'll see who have aortic stenosis who simply don't have AFib, right? Because the second you throw AFib into the mix, you've got a bridge for, and we'll talk about it when we come to that. Randy, do you want to read AF? You may have to unmute yourself, Randy.
Sorry. Okay, AF is a 60-year-old man with paroxysmal atrial fibrillation scheduled to undergo a screening colonoscopy. Warfarin must be discontinued in case a biopsy is needed. When the patient is in atrial fibrillation, he is asymptomatic. He also has hypertension, type 2 diabetes. He has never had a stroke, transient ischemic attack, or history of venous thromboembolism disease. Medications include metoprolol, metformin, and warfarin. On physical exam, pulse rate is 65. Other vital signs are normal. Cardiac rhythm is irregular. Laboratory studies reveal an INR of 2.3. In addition to discontinuing warfarin, wasn't away. Which of the following is most appropriate treatment?
All right, we're almost there. I'm gonna share the results. Let's see. Come on, a couple more votes, guys. We got this.
Great. So we're almost 50-50 between no bridging and switch to intravenous unfractionated heparin. Okay. So those who switch to intravenous unfractionated heparin, raise your hands and tell us why. And those who don't want to bridge, raise your hands and tell us why. Actually, one for each is enough, not everyone.
I can say why not to bridge.
Okay.
Yeah, because like I know that it used to be before that if I want to bridge, I would bridge him with low molecular weight. I don't know if there's any indication to bridge him with unfractionated heparin instead of low molecular weight. But I don't think his age is 60. So talking about AFib and CHA2DS2-VASc, I know they say now it has to be more than 4 to 5. If it's only for AFib and there's no mechanical valve, as we were saying before, AFib, you have to have CHA2DS2-VASc at least, I think 4, and they get 4 or more, or like 5 or more, even 5 actually, or more, and so that he can qualify for bridging. Otherwise, you can just discontinue warfarin. But I think you need to repeat this INR for our GI colleagues to be happy. It should be, I think, less than 1.5 before they will do the procedure for him.
Thank you so much. And what that data that you're quoting with that CHA2DS2-VASc cutoff of 4 to 5 is based on what trial?
I don't remember the name. If anyone can have the bridge.
There you go. It's also easy to remember, right? They like come up with this name like bruise control and bridge. I think I was working with Dishant last week and I was like, yeah, like, have you looked at the bridge trial? And he's like, why do you keep quoting trial names? I'm like, because they're so catchy. Like someone, you know, whoever designs the trials has spent a lot of time thinking of a great name that'll stick in our memories. Great. And so maybe someone who decided to bridge wants to speak up. Medicine is not black and white, right? Like there's always going to be someone on the other side.
It's impossible to speak after man.
Yeah, I know some attendings are intimidated by Man. Okay. So correct answer is Man's answer. And the reason is the bridge trial. It's worth looking at. It's really a beautifully done trial. Large trial, 1,800 patients that were heading towards an elective procedure, right? So they had a lot of time to do this. And so they randomized to low molecular weight heparin, exactly like Man mentioned. You know, if you have an intact kidney function, trying to do a heparin drip is only frustrating, or placebo. And in order to be enrolled, you had to at least have CHA2DS2-VASc of minimum. You had to have at least one risk factors. The interesting thing to remember about the bridge, which was published in 2015, is that if you looked at the mean score, the maximum number of patients in this trial either had a CHA2DS2-VASc of 2 or 3. And the higher CHA2DS2-VAScs were not common. And we're going to look at that data together. So you know what the trial's sort of design looked like. The star is when their procedure was planned. They all had an interruption of their warfarin 5 days prior to the planned procedure. The INR was allowed to drift down. And exactly like Man said, once it was under 2, you would either be randomized to dalteparin, which is a low molecular weight heparin, or placebo, which was interrupted typically 24 hours prior to planned procedure. And then immediately after the procedure, they were resumed on dalteparin versus placebo. And basically, the INR was built back up, and these were interrupted once they were therapeutic. Okay. Any questions about the study design? Have you guys looked at this before? Yes, no, maybe. So here are the outcomes. And they were looking as primary outcomes, obviously, for stroke arterial thromboembolism, which encompasses stroke, TIA, systemic embolism. And obviously they were looking at major bleeding. So look at your two columns. The ones who weren't bridged had 4 versus those who were bridged had 3 episodes of arterial thromboembolism, which includes stroke and TIA. And for major bleeding, which is fairly obvious, it was more than double for those who were bridged. They looked at secondary outcomes that included death, MI, DVT, PE, and minor bleeding. And obviously it's not unexpected that even minor bleeding was higher for those who were bridged. To me, what was really interesting was that the MIs were higher for those who were bridged. So I was sort of puzzled by that a little bit. Any explanation for why that might be? There's always been this theory around vitamin K antagonists, right? So warfarin, that when you're starting warfarin or when you're taking warfarin off, there is this state of being hypercoagulable in the midst of that. And so that study design, right, where you're interrupting it and then you're letting it drift down, you're starting the dalteparin, and then on the flip side, you're building it back up. You've got to wonder what that's doing to someone's clotting. This is the thing, if you want to really stick something in your memory, right? Because when you're doing these POMAs, you guys are all very good at quickly calculating a CHADS-VASc. This is not the CHADS-VASc, this is the CHADS-2 because the study is from 2015. Just look at the study distribution. So right till about a score of 3, I would say even maybe 4. 10% of the study population had a CHADS-VASc of 4. 5 and 6, they really didn't have too many patients, right? So I personally feel pretty comfortable not bridging till about 4. After that, I get really uncomfortable because there's not enough data, right? So this is sort of the outcome of the of the bridge trial, that 2.3 is around the mean for which you should feel comfortable. But in practice, what we're doing right now is we're not bridging for under 4. We bridge if your CHADS-VASc is over 4. We bridge if you have a mechanical prosthetic heart valve, or if you have a newly inserted, and new means within 3 months, newly inserted biological prosthetic valve. We bridge if you've had mitral valvular repair. Again, sort of we discussed this in a different context, but mitral valvular repair just seems to have a higher risk of embolism. Again, within 3 months, recent venous thromboembolism within 3 months. So if you want to commit something to memory, it's 3 months. You're looking for that recent event. And of course, you bridge for thrombophilia. Questions? These are old guidelines, but even if you look at the guidelines which came out this time last year, they're very similar. Kirtana?
Yeah, sorry, Dr. Singh. I don't know if this was covered for a mitral valve that's been replaced and it's been more than 3 months, but it's not mechanical, it's bioprosthetic. Is the guideline that you don't need bridging?
Correct. For bioprosthetic mitral, in the absence, and again, we did discuss this for aortic, we didn't specifically do it for mitral, but again, in the absence of AFib and in the absence of prior stroke.
Yeah. Okay, thank you.
Bioprosthetic. Mechanical is always bridge for mitral.
Yep, thank you.
Okay. Gabby, do you want to read case 4?
Sure. So we have EQ, who's 63-year-old man who's an Apixaban for AFib. He's got OA of the right knee and is scheduled for a right total knee arthroplasty next week. And how should his anticoagulation be managed peri-op?
This is sort of a very broad question. If you want to unmute yourselves and tell me exactly what you would do, right? So you walk in, it's Thursday, he's scheduled for the OR, let's say Monday, and as a really good PGY3, or let's say like a brilliant PGY2, you're putting down recs saying like, what is the exact time you're stopping the Apixaban? What is the exact time you're resuming the Apixaban? That's what I need from you. Again, just unmute yourself. This is, we didn't create a poll for this. Just feel free to just speak up. Apixaban is what he's on, right? So EQ, Eliquis.
I can take this one. So it seems like it's a minor to intermediate risk surgery. I don't expect there to be a lot of bleeding. And I think we're missing a few information, like what is his creatinine clearance. I think that would, and like that would decide when to hold it. If he has a normal kidney function, he's going for a minor risk procedure, it would be like a 24 hours that he really needs it to be held for. And it would be higher if his kidney clearance was less than 30, or if it was like a higher risk procedure.
Nail on the head. Yes, I deliberately skipped the creatinine clearance for that reason, that you need to think about it. You need to look at it, you need to look for it, and then look at it before you make a decision. So preoperatively, it depends on the agent. Apixaban, which is in the bottom row, exactly like what Michelle said, look at the creatinine clearance. Usually for a low risk procedure, such as knees and hips, which are considered low bleeding risk, 24 hours prior to procedure is enough. If you have poor sluggish kidneys, you need to do it for 48 hours. And you double those numbers for high risk surgeries. You're just looking at the bottom row here. Okay. And obviously each of your DOACs has slightly different metabolisms and slightly different half-lives. So it's always helpful to pull up a chart, and I'll send you the link for the charts that I love, to know your agent and to know how long to hold it. The good news is Apixaban and Rivaroxaban, your most commonly used drugs, which is Eliquis and Xarelto, are nearly identical in what you have to do, right? Dabigatran, which is Pradaxa, the annoying one, which every old person will bleed on, which the GI guys hate for good reason, is a little bit trickier, right? And so did you, Michelle, mention when would you resume it?
I haven't, so it would be 24 hours. I think we were saying it's like 24 hours, and then if you really want to bridge it, you can do like a one prophylactic dose of heparin at 12 hours, like just a prophylactic or therapeutic dose, and it would be different for like dabigatran because it has like a slower absorption. And I remember all this just because I listened to your lecture like recently, so from last year. I'm not gonna pretend that I normally know these things.
I was gonna say you're almost too close to the right answer.
No. I had to prepare a lecture on this, so this is the only reason why.
I love it. I love it. So this according to me, this is probably one of the best resources. So if you want to save something in your phones, that's like a quick cheat sheet. This is the best cheat sheet that's out there. This was published in JAMA in 2019, so pre-COVID. But what I really like about it is like it's like a dummy proof, right? If you're surgeon, like I'm not saying surgeons are great, but if someone's arguing with you, they're like, we don't want to stop it, we don't want to start it, just stick this chart, this sort of figure in your POMA, and it gives them a lot of direction on what to do. And so they're stratifying exactly as we had discussed by high risk and low risk surgical procedures, and they're stratifying also by creatinine clearance. Specifically, they're doing it for dabigatran on this chart, but it's also always worth it to stratify for both Apixaban and Rivaroxaban based on creatinine clearance, right? So you can, for a low risk procedure, start within 12 hours. And so exactly what Michelle said is, at 12 hours post-operatively, the reason you give that little dose of a subacute heparin or subacute Lovenox is because knees and hips and a lot of joints, they love to clot. And surgeons hate it when they have post-operative venous thromboembolism. And so you're just covering all your bases by doing this. Then there's a lot of data also on, let's say your patient wasn't on Apixaban preoperatively, you can sometimes help them with low dose DOACs postoperatively for 30 days for VTE prevention. I like history, and so if anyone is going into hem-onc, it's interesting to know. So Pradaxa was the first one to be approved almost 12 years ago, followed the next year by Rivaroxaban, followed by Apixaban, and then there was a bit of a lull, and then Adoxaban came out with a big bang in 2015, and they really started marketing themselves towards venous thromboembolism, specifically in malignancy patients, but the reality is you can use any of them, and not just Adoxaban. They just made that their marketing strategy. The same year as Adoxaban, Idarucizumab came out, which is the reversal agent for dabigatran. I think it's called, what is it called? They called themselves something like stopping Pradaxa, like Prad Stop or something. They have a catchy trade name. And then in 2018, which was very reassuring to everyone, right? So Andanexet came out, which is the reversal agent for all your anti-10A DOAC. So it reverses Rivaroxaban and Apixaban and Adoxaban. And has anyone used Andanexet and Xanet Alpha and Xanet? And I'm pronouncing it wrong, but has anyone used it? So what we could do.
Not sure. Is it available in Mount Sinai West?
Yes, but you have to call it in. So you can order. This is really annoying. You can order Idarucizumab on Epic. Like you can sit down and just put the order in, and then they'll call you and say, "Oh, what do you need it for?" And not even that many patients are on Pradaxa. The majority of patients are on Apixaban, Rivaroxaban. But for Andanexet, you have to call it in, and they'll make it available. I'm thinking. Sunny, can you Google Andexanet NEJM YouTube? There's like a great little 2-minute video. I think we have the time to look at it. Yeah, I can Google that actually.
What is it again, Dr. Singh?
So it's the reversal agent. It's Andexanet NEJM, and just do YouTube. It's like a 2-minute explanation for how it works and how the trial pushed it through. It wasn't even a large trial that pushed it through, but it was such good data. It was.
I'm hopeful this is it. I can share.
Oh yes, Praxbind. There you go. That's what Idarucizumab is called. Yes, that's it.
Factor Xa inhibitors such as Apixaban and Rivaroxaban are convenient to take but can cause bleeding complications. Many physicians hesitate to use them because there's no easy way to reverse the effects of treatment in the event of an accident, internal bleeding, or a surgical emergency. Andexanet is a fragment of Factor Xa that was designed to rapidly reverse the anticoagulant effects of these inhibitors by preventing their binding to authentic Factor Xa. To test the efficacy of Andexanet, a small phase 3 trial was designed with healthy older volunteers as the participants. They were given either 10 milligrams of Apixaban or 20 milligrams of Rivaroxaban daily until steady-state anticoagulation had been achieved. Then intravenous Andexanet was given to determine whether the effects of these anticoagulants on blood clotting could be reversed, and if so, what the side effects might be. The primary outcome was the mean % change in anti-Factor Xa activity, which was significantly reduced both in participants who received a bolus of Andexanet and in those who received a bolus followed by an infusion of the drug. Participants who received a bolus of Andexanet had fully restored thrombin generation within 2 to 5 minutes, and this effect was sustained while Andexanet was given as an infusion after the bolus. No serious adverse events were noted. The authors conclude that Andexanet reversed the anticoagulant activity of Apixaban and Rivaroxaban in healthy older volunteers within minutes and for the duration of infusion, without evidence of clinical toxicity. Full trial results are available at nejm.org.
Dr. Singh, you're on mute in case you wanted to say something.
So sorry, there was like stupid emails inundating my view. Can you guys hear me?
We can, yeah.
Okay, perfect. Sorry about that. Let me just redo some of my screen and go back to our lecture.
You have multiple screens open and Dr. Singh asks you to share a video in the middle of academic hour. I know
Yeah.
the feeling.
Sorry about that. Yeah, like because I'm also on Star and I was also trying to like spy on Epic a little bit. Okay. Great. So that was Andexanet. I'm glad we know how to say it now. We all know the mechanism of action, but just a quick reminder, right? So the bigatran is a direct thrombin inhibitor, and everything else that you're using much more commonly is a factor 10A inhibitor. So rivaroxaban, apixaban, adoxaban, they're all factor 10A inhibitors.
Are you trying to share your screen, Dr. Singh?
Oh, I still haven't shared? Great. I'm behind the times. Yes, of course I haven't shared. There you go. Is that better?
Much better.
For some reason, bizarrely, I stopped seeing your videos. Oh, no, you're back. Okay, perfect. Zoom falls to this one like back screen where it's the kids without their videos, and then there's a front screen with everyone with their videos. Okay. So it's worth it to just spend 5 minutes going over some of the differences in the medications that we've gotten so used to prescribing. So we'll focus on the ones that you're prescribing the most, which are rivaroxaban and apixaban. And you can kind of look at the dabigatran on the side because you still have some folks that are coming in on Pradaxa. So these are all approved for non-valvular AFib. They're all approved for venous thromboembolism treatment, and they're all approved for venous thromboembolism prevention after orthopedic surgeries at lower doses. It's worth it to memorize their half-lives. Rivaroxaban with the shortest half-life of about 6 to 9 hours, apixaban at around 12 hours, and dabigatran just slightly more than that. This is sort of where you should maybe focus your attention is the excretion. So rivaroxaban or Xarelto is excreted mainly through the kidneys, about 60, 70%, a little bit through the liver. Apixaban is exactly the opposite. It's excreted mainly through the liver and about 25% through the kidneys, but there is still some renal excretion. Both dabigatran and adoxaban also have renal excretion. And you can monitor these, right? So the fear used to be back in the day, you can't reverse it, you can't monitor it, which is just not true. You can monitor them. You can check anti-10A levels. You can check rivaroxaban, apixaban, dabigatran levels through Quest. A lot of outpatient folks have gotten really good at doing this. And you can reverse them like we just saw, right? So in addition to Andinexit, you can use, what's PCC? I hate abbreviations and I wonder why I put it in.
Prothrombin complex concentrate.
Excellent, good. And we'll skip this. All right, let's go on to the next question, which is kind of pertinent to everything we've been discussing. Let's see, Nick, you're not eating. Do you want to read case 5?
Sure. So BH is a 93-year-old female who 6 months ago was found down by a home health aide. At that time, she was brought to the hospital and diagnosed with AFib and left MCA stroke. EF 60%, creatinine 1.1. She was on aspirin at the time. Her PCP added dabigatran 150 BID. Now she's readmitted for massive GI bleeding. How do we manage her bleeding?
It's pretty common, right? I mean, I think most of us, if you've been rotating at a single site, you'll see the same patient you discharged come back. And so this is also just up for discussion. What would you like to do based on all the knowledge you just acquired? Teresia, what would you do?
Yeah, I would probably, I mean, if it's massive GI bleeding and she's hemodynamically unstable, I would try to give something I'm not sure which one. I guess maybe I would start with like FFP or something, but I'm not sure. Then maybe give some.
Yeah, so I mean, the basic idea is to think about what are the things you can do besides, you know, physically going in, right? So like really have the option of rushing GI and putting a colonoscopy up and, trying to quickly stop whatever is bleeding, or do you have other more sort of, less invasive ways of doing it? And it's exactly what we just discussed, right? So depending on what your DOAC is, you should consider using a reversal agent. You should ask people when their last dose of their DOAC was, and based on the half-life that you should consider using the reversal agents. So if you ask this lady, when did you last take this dabigatran or Pradaxa? And she says 6 hours ago, and you know that the half-life is 12 to 18 hours, you should then consider using the adagrasib, right? And if her agent was something else, then you would use Andonexid. And like Maan said, is Andonexid available for a EPIC order? It's not. You have to call it in. But prothrombin complex concentrate is available for an EPIC order, and you can use that for any of these agents. You can use it for the 10A inhibitors, you can use it for direct thrombin inhibitors, you can use it for all of them. And so we'll skip this in the interest of time. But after asking this lady a few more questions, she had taken her dabigatran about 8 hours before coming to the hospital. And therefore, this was actually done at West. It was done from one of my patients. And I was really surprised because I hadn't seen this agent used before. And I was like, this is really exciting. Not only do we have this agent, we're actually using it. And, going back, we started looking at some data to see what is safer in a lady this age, with this kind of creatinine clearance. What is the safest agent? And Pradaxa definitely is not the safest agent. With an increased creatinine clearance, a decreased creatinine clearance and increased creatinine and older age, Pradaxa was probably the worst agent to start her on. Apixaban would have been slightly safer. All right, let's move on to the next case.
Hey, Dr. Singh, sorry, can I ask a quick question? So we saw from that really wonderful little video that the Andonexid doesn't have particularly bad, or it doesn't have adverse effects like proclotting. But for the other agents, is there any concern, like if this person had been altered, you can't ask when's the last time they took their medication? Would you be concerned and not want to give it if you're not sure what the window of time was that they?
Yeah, I think so. The safety profile for the two reversal agents is extremely similar. They don't have a terrible side effect profile. We always, obviously, we base these decisions on saying, will it work if I give this agent, right? Because am I in that window period where there's something to reverse? There hasn't been enough trial information to say, should you start throwing it at everyone coming in with a bleed, irrespective of time window, irrespective of mental status and things like that. But I hear your concern, right? Here's an old woman who's had a stroke before. She has AFib. You're kind of like shutting down her dabigatran with this reversal agent. Does that make her more prothrombotic, right? So she's bleeding now, and would you give a reversal agent, make her more prothrombotic, and then she'd stroke out? I totally hear your concern. I think that decision has to be made based on hemodynamic stability and things like that also. Yeah, so if you had a little bleed, but you're sitting there super comfortable with a robust hemoglobin, there's no need to reverse. Do you want to read case 6?
Sorry, was that me? I didn't hear.
Yes. And don't worry, just like you, I can never find the mute button either.
Sure. So AP is a 60-year-old man with a history of coronary artery disease presenting to you for a preoperative assessment prior to cholecystectomy following a single episode of biliary colic that occurred 3 weeks ago. Ultrasonography documented cholelithiasis without gallbladder edema. 6 months ago, a drug-eluting stent was placed in her left anterior descending coronary artery. He also has hypertension. Medications are lisinopril, aspirin, clopidogrel, and metoprolol. He has modified his diet and has not had any additional abdominal discomfort since the episode 3 weeks ago. On physical exam, temperature is normal, blood pressure is 125/80, pulse rate is 60, and respiration rate is 12 per minute. BMI is 26. A normal carotid upstroke without carotid bruits is noted. Jugular venous pulsations are normal, and normal S1 and S2 are heard without murmurs. Lung fields are clear, distal pulses are normal, and no peripheral edema is present.
Yeah, so as you can tell, the first 5 cases I wrote based on some of the cases I'd had, and this one I lifted from MixApp. Therefore, the stem is much more robust. All right, what would you do? And just in the interest of time, we're going to rush because we have 4 minutes left. I want to show you a couple of more slides before we finish. Just like pick any option.
Time, Dr. Singh. Take your time. We
Okay.
can start later because we're moving on to afternoon report, so we have a little longer.
Oh, you're doing an early afternoon report?
Last minutes left, yeah.
Got it.
Keep voting, we're almost there.
I think it's a pretty common scenario, right? A lot of these biliary colics, these sort of cholecystitis, et cetera, are managed on medicine services conservatively. And then we have a pretty good idea usually of their coronary history, and we have specifics about their stents and everything. And a lot of times patients will say, hey, doc, like, when is my gallbladder coming out? They put a substantial amount of pressure on you. Like, I'm just going to have another episode of like this infection and pain. When are you bringing it out?
Probably we need to know also why was the stent placed? Was it an MI presentation or was it an ACS?
Excellent. It makes a difference. Yes, yes. So you all answered correctly. And Man, your answer is like really nicely embedded in this one recent European guideline that came out 2021. And before we finish, I'll show it to you because they exactly do that. They risk stratify by elective stent versus stent in the settings of MI, and it's done a little bit differently for both. I think in general, all of you know this, right? No one does a balloon angioplasty anymore. No one does a bare metal stent anymore. Bare metal stents are done only in the scenario where you foresee a fairly urgent surgery coming up within the next 4 to 6 weeks. Something as urgent as a major tumor resection, which cannot wait for 6 months, and so on. Drug-eluting stents, by and large, the guidelines have been to wait for 12 months from the time that they were put in. Does anyone disagree with this? Does anyone know about these cool new kids on the block?
I have a question. I mean, in the case of a patient with high bleeding risk or recent PCI, now there's some data that supports discontinuing DAPT after 1 month of DAPT if the PCI was elective and also with some stent platforms like Synergy or Endeavor from Medtronic. So, I mean, yeah.
That's it. So you just mentioned the new kids on the block. So for the old, for the old drug-eluting stents, right? My generation of drug-eluting stents, you had to wait. Like, the most conservative thing you could do was wait for 6 months. But for a lot of the new kids on the block, exactly like you said, if you haven't had the stent put in the settings of an MI, right? It was an elective stent that was found, like you basically found it incidentally, the blockage, and you stented it. And it's one of the new generation drug-eluting stents. Then yes, 3 months, for some even 1 month is now being recommended. You're right.
Yeah, sorry. And the other thing, bare metal, even if the patient has active cancer, is they don't use it anymore. It's like, I think in the last American guidelines, it's like class 3, it's harm.
Thank you. Yeah, I haven't looked at those, but it should be. It's quite a lousy thing to do. And with all of these new drug-eluting stents, you really don't need to use it, right? This is also borrowed from the ACC. It's also very similar to what we just discussed. Again, in the interest of time, look at it when you have some downtime. But the better guidelines to look at, I'll show you the other better guidelines to look at. I don't know the names like Francisco was mentioning, but I recall just from doing some research prior to teaching, they're called like everolimus eluting stents or zotorolimus eluting stents. They're all these. And so you really want to look into the specifics and call the cardiologist and say what drug eluting stent it is before you make that decision with the surgeons. Let's just spend a couple of minutes going over just don't think we really have the time, but so let's, just spend a minute per slide. So aspirin, so it's probably the most commonly prescribed antiplatelet drug. Its mechanism of action, just a reminder, is the irreversible inhibition of the cyclooxygenase 1 and 2 enzymes, right? So just remember that it's irreversible, and the action of COX is necessary, right? You have to convert arachidonic acid to prostaglandin H2, and then the prostaglandin H2 is rapidly converted to several bioactive prostanoids, right? So you have thromboxane A2, and that's the most potent vasoconstrictor and inductor of platelet aggregation, right? So that's basically where your money is. So aspirin itself has a super short half-life. It's it's got a half-life of about 6 hours. But the problem is, because of the irreversible inhibition of COX enzymes, it lasts as long as the platelet lives, so which is 8 to 9 days. So just remember that you need 8 to 9 days of interruption of aspirin to truly go back to having normal platelet function. People have asked me a lot of times on consults, what is the effect of NSAIDs on platelet function? And it's considered somewhat shorter than that of aspirin. The effect of most NSAIDs would normalize in about 3 days. Okay. I'll skip the POISE-2 trial, although the POISE-2 trial is worth looking at. And then just a quick word about clopidogrel, prasugrel. These are inhibitors of ADP receptors, which are also called the P2Y12 receptors in platelets. Physiologically, the union of ADP with its receptor will increase the intracellular calcium, activate the GP2B3A platelet receptor, and then basically stabilize the platelet clot, right? So again, you have to remember clopidogrel and prasugrel are prodrugs, and the active metabolite irreversibly, again, you want to remember, it irreversibly affects platelet function in a time and dose dependent fashion. So again, you want to interrupt their use 5 to 7 days prior to non-cardiac elective surgeries, 5 to 7 days. So it was 8 to 9 days for aspirin, 5 to 7 days for clopidogrel, prasugrel, and then for ticagrelor, it's also about 5 days. And I'll skip the mechanism of action for that. We'll skip. Before I finish, let me just show you. These are the guidelines that I think are so beautifully written with just, beautiful sort of pictorial graphics. I'll link it in your chat. This is what you were asking, Man. It actually tells you exactly what to do in the settings of elective PCI versus acute coronary, sort of an MI with PCI. What do you do with your triple therapy? When do you transition to dual and then to monotherapy? And if there is like one beautiful write-up, it is this 2021 European Heart Rhythm Association sort of practical guide. Even if you don't read through it because it's too many pages, when you have a very specific question in your sort of, specific patient, go to it and just go to the graphic that you're looking for. And it gives you sort of multiple clinical scenarios and things to do. Let me see how I can link this for you guys. Doesn't work like that. I'll email it to you. It's easier. I'll email it. Any questions, guys? These guidelines do all kinds of cool things. Like they'll tell you how to get someone off of warfarin onto a DOAC, off of a DOAC onto warfarin. Basically, like draws beautiful pictures for everything.
I have a quick question. Hi, Dr. Singh.
Hey,
For the DOACs, there was a slide that said, when you stop them 2 or 4 days before, based on creatinine function, if it's dose reduced DOACs, does that still stand or?
It still stands. Yes, it absolutely does. Because just remember that dose reduction is also based on creatinine clearance and age.
That's why I'm
right?
asking. Yeah. Okay.
It absolutely stands.
Thank you.
I'll email you guys my presentation, and I'll email you this the European guidelines. I think they're both, the European guidelines are beautiful. So anyone going into hemonc or cardiology should go through them. Or hospital medicine. All right.
Thank you so much, Dr. Singh. I was trying to find the guidelines, but I'm not quick enough, so maybe.
Yeah,
Yeah, the link is an Outlook link, so we'll find the guidelines, and Dr. Singh.
I'll send you the
also-
PDF, guys. I'll send you the PDF. Yeah, I have it saved in my like Cyanide drive or something. I'll send you the actual PDF.
Yes, and ESC is definitely the most beautiful guideline writer, better than ACC and RHA. Thank you, Dr. Singh, and for everyone else, I'm gonna share the quote with you for attendance, and we can take maybe a 5-minute break.